5. Medical checkups I'd never get after 65. Doctor explains. The narrative begins with a poignant vignette illustrating a critical flaw in the modern medical approach to aging. Consider a man, vibrant and robust at 71, comfortably enjoying his retirement years. He is sharp-witted, meticulously maintaining his own sprawling lawn, and regularly driving himself to his cherished Tuesday poker games, a testament to his enduring independence and zest for life. Despite his apparent good health, his devoted wife, driven by a natural concern for his well-being, finally convinces him to attend a physical examination he had diligently avoided for the past 2 years. During the appointment, the doctor performs a routine checkup, confidently declaring, "Everything seems fine." Yet, this reassuring assessment is immediately followed by 6 deceptively innocuous words that shatter the tranquility of their lives. Let's just run a few tests. This seemingly benign suggestion marks the insidious beginning of a cascade of events that irrevocably alters the course of the man's existence. Just 3 short months later, this once self-reliant individual finds himself in recovery, grappling with the aftermath of a medical procedure he never genuinely required for a condition that, left undisturbed, would have never truly impacted him. He battles unforeseen complications, entirely unrelated to the minor ailment that initially brought him to the clinic. The cherished version of his life, the satisfaction of tending his garden, the camaraderie of poker nights, the profound sense of personal autonomy, that life, as he knew it before that fateful appointment, has been tragically extinguished. This deeply unsettling narrative, far from being an isolated incident, resonates with a disturbing frequency within the medical literature and even has a recognized name: the diagnostic treatment cascade. My name is Dr. Thomas, and as a physician specializing in cardiovascular health and aging, my work centers on understanding the profound transformations the body's circulatory system undergoes after the age of 60. More importantly, I dedicate my practice to unraveling the implications of these changes for how we approach medical decision-making in older adults. Through my extensive clinical experience with patients over 60, a recurring and disquieting pattern consistently emerges. Individuals who enter a routine medical appointment feeling entirely healthy, only to emerge on the other side grappling with an array of issues they never experienced before the initial diagnostic tests began. This pervasive pattern is not merely anecdotal. It possesses a distinct mechanism, a recognized nomenclature, and once its intricacies are understood, it will fundamentally reshape your perspective on every future visit to a doctor's office. Let me present a statistic that should command your immediate attention and provoke serious reflection. Studies consistently estimate that a staggering 15 to 25% of all medical procedures performed annually across the United States are, by medical consensus, deemed unnecessary. However, the most critical and often unacknowledged aspect of this alarming figure is that this percentage dramatically escalates after individuals cross the age of 65. This sharp increase is not because older patients are inherently sicker or more fragile. Rather, it is because the intricate risk-to-benefit calculus of medical interventions undergoes a complete and fundamental shift once a person reaches 65. The unfortunate truth is that our current medical system, with its hurried 15-minute appointment slots, is simply not designed to adequately perform this nuanced, age-adjusted mathematical assessment. This phenomenon is best encapsulated by what we term the cascade effect, an escalating chain of events that often begins with the most innocent of intentions. It operates in a predictable yet perilous sequence. A single routine diagnostic test uncovers a minor abnormality, often clinically insignificant. This discovered abnormality, regardless of its actual threat level, then triggers a recommendation for a follow-up imaging scan. The scan in turn may identify a suspicious area, prompting the suggestion of a biopsy. The biopsy, designed to provide further clarity, can then lead to a more invasive medical procedure. Subsequently, this procedure, itself an intervention, might unfortunately cause a complication. Thus, a person who initially walked into the clinic feeling perfectly healthy and entirely asymptomatic is now burdened with managing a complex medical situation, a reality they utterly lacked before consenting to that initial, seemingly harmless test. Crucially, the cascade does not originate with a major surgery or a severe diagnosis. It commences with that very first diagnostic test, and it is precisely this insidious progression that forms the central theme of our discussion today. I am committed to guiding you through 5 specific medical checkups that, based on my clinical expertise and the available data, I would personally urge you to reconsider after the age of 65. My cautionary advice is not a condemnation of modern medicine itself, which undoubtedly offers life-saving interventions. Instead, it is rooted in the undeniable fact that after 65, the delicate balance of the risk-to-benefit equation dramatically shifts. Regrettably, very few doctors engage in this critical mathematical assessment openly and transparently with their patients. I will meticulously illustrate precisely why this shift occurs, share compelling accounts of what I have witnessed happen to real patients in my practice, and ultimately provide you with a set of specific, empowering questions at the conclusion of this video. These questions are designed to utterly transform the dialogue you have during your very next medical appointment, enabling you to become a more informed and proactive participant in your own healthcare. I encourage you to stay with me through the entire discussion of all 5 checkups. You might find that number 3 is particularly surprising, as it involves a test that, on the surface, appears to embody pure common sense and responsible health management. And checkup number 1, the final item on our list, is perhaps the most critical of all. It is a routine screening almost universally accepted without question, despite the underlying data being more profoundly troubling than nearly any other item we will discuss. Before we delve into the specifics, I invite you to share your city or state in the comments section below. I genuinely read every single response and value knowing who is part of this growing community. It means a great deal to me to see the incredible network that has formed around this channel. However, before we proceed, there is one foundational concept that is absolutely essential for everything else I will discuss today to truly resonate. I refer to it as the longevity lens, and understanding its principles is paramount. Here is how it functions. When you are, for example, 50 years old, engaging in routine medical screening represents one of the most advantageous investments you can make in your long-term health. The logic is straightforward. You identify a potential problem early, you initiate appropriate treatment, and in doing so, you potentially secure yourself an additional 3 decades of healthy, high-quality life. The mathematical equation is clear, and the investment unequivocally pays substantial dividends. However, after the age of 65, 3 fundamental factors profoundly alter this seemingly clean mathematical equation. Firstly, a significant number of medical conditions that routine screening might uncover in adults over 65 will, in actual fact, never cause you any tangible harm. These conditions often progress at an exceedingly slow rate. They typically produce no discernible symptoms, and in a considerable proportion of cases, you will simply outlive them without ever experiencing their adverse effects. Yet, the moment a positive or abnormal result appears on a medical report, the established medical protocol lacks a leave it alone option. Instead, it possesses an undeniable treatment button, and more often than not, that button is instinctively pressed. Secondly, your body's inherent tolerance for medical intervention is fundamentally different from what it was at 50. The surgical procedure from which a 58-year-old might resiliently bounce back in a mere 2 weeks can, for a 73-year-old, translate into months of arduous recovery, potentially compounded by severe complications, a heartbreaking loss of independence, and a drastically diminished quality of life that bears little resemblance to their pre-intervention state. And thirdly, there is the ever-present specter of the cascade effect, that treacherous sequence initiated by a single test, followed by one abnormality, setting in motion an escalating chain of events that began from a place of feeling perfectly well. It is absolutely crucial to keep this longevity lens firmly in mind as we explore every single item on this list. All right, let's delve into the specifics, beginning with checkup number 5. Routine PSA, prostate-specific antigen. Prostate testing after the age of 70 in low-risk asymptomatic men. It is imperative that we approach this topic with utmost precision, as it is exceptionally easy to misinterpret. I am emphatically not suggesting that prostate cancer is an illusion or that PSA testing is devoid of all value. My assertion is that for men over the age of 70 who exhibit no concerning symptoms, possess no relevant family history of prostate cancer, and have no prior medical concerns regarding their prostate health, the comprehensive data surrounding routine PSA testing reveals a nuanced and often untold story. A story that most men sitting in their doctor's offices have regrettably never heard. The core issue lies here. A PSA test possesses the capability to detect a prostate cancer that is, biologically speaking, barely progressing. We are talking about an indolent, slow-growing tumor that, if simply left undisturbed, would almost certainly never spread beyond its origin, never cause any symptoms, and in the case of a 71-year-old man, would, with near certainty, never shorten his lifespan. Such a man would live with it rather than die from it. However, the instant that PSA test result registers as elevated, the medical system, bound by its protocols, does not wait. Biopsies are promptly ordered, referrals to specialists are swiftly made, and an array of daunting treatment options are presented. For a 71-year-old man who is otherwise in excellent health, embarking on treatment for low-grade prostate cancer can entail radiation therapy, a regimen of hormone therapy, or invasive surgery. Each of these interventions carries very real and often significant risks to urinary continence, sexual function, energy levels, and overall quality of life. Consequences that can be devastating. Recognizing this pervasive problem, the American Cancer Society has specifically revised its guidance. For men with a life expectancy estimated at less than 10 years, or for older men who are at average risk and present with no symptoms, the potential risks associated with the detection and subsequent treatment of a slow-moving cancer frequently and decisively outweigh any conceivable benefits. Allow me to share the compelling story of Raymond. Raymond, a spry, 74-year-old retired electrician from Tulsa, Oklahoma, epitomized good health. He was fit, consistently active, had no family history of prostate cancer, and experienced absolutely no urinary symptoms whatsoever. During his routine annual physical, his PSA test results returned as slightly elevated. A subsequent biopsy confirmed a low-grade, slow-growing prostate cancer, characterized by a Gleason score of 6, which, in medical parlance, signifies the least aggressive form of prostate cancer. His urologist, adhering to standard practice, recommended radiation therapy. Raymond, placing his trust in the medical recommendation, underwent the full course of treatment. Within 8 months, his life had undergone a profound and disheartening transformation. He found himself grappling with chronic fatigue that systematically sapped his energy each morning, urinary urgency that dictated and severely restricted his daily activities, and a general quality of life that had plummeted in ways he had never possibly anticipated. When he sat down with me a year post-treatment, his words resonated with a heartbreaking clarity. "I felt better before they found it than I do now that they fixed it." This sentiment, far from unique, appears with a troubling consistency throughout the medical literature, a consistency that should compel every man over the age of 70 to pause and deeply consider before consenting to a routine PSA test. What then should be done instead? If you are experiencing urinary symptoms such as hesitation, changes in flow, or increased frequency at night, absolutely discuss these concerns with your doctor. These symptoms are significant and warrant investigation. If you have a strong family history of prostate cancer, this significantly alters the equation and screening might be more appropriate. However, If you are 70 years of age or older, entirely asymptomatic, and fall into the average risk category, the pivotal conversation with your doctor should not revolve around whether to screen. Instead, it should be focused on a crucial, often unasked question: what would we realistically do if we actually found something? And equally important, would that potential treatment pathway genuinely improve my life, or would a strategy of watchful waiting, carefully monitoring the condition, be a superior approach? Posing this single question alone often has the power to completely reframe and alter the entire medical discussion. Moving on to checkup number 4, routine bone density, DEXA, screening when paired with automatic long-term medication prescriptions. Before anyone misinterprets my message and prematurely dismisses this discussion, let me be unequivocally clear. Osteoporosis is a very real medical condition, and falls in older adults can indeed be devastating, leading to severe injuries and a significant loss of independence. My intention here is to be scrupulously precise, as there is a fundamental distinction between questioning the utility of a diagnostic test itself and challenging the automatic, often unquestioned medical pipeline that frequently follows a positive test result. A DEXA scan, as you know, is designed to measure bone density. If the results indicate low bone density, many medical practitioners immediately gravitate towards prescribing a class of medications known as bisphosphonates, brand names like Fosamax, Boniva, Actonel, which you have likely encountered in various advertisements. The implicit and often explicit message conveyed is that low bone density directly equates to the need for medication, and that medication, in turn, guarantees protection against fractures. However, this pervasive message often omits crucial information. Long-term use of bisphosphonates, particularly when extending beyond 5 years, has been demonstrably linked to a rare but exceedingly serious condition called atypical femoral fractures. These are stress fractures that occur in the thigh bone, paradoxically the very bone these medications are intended to protect. Such fractures can be incredibly severe, frequently necessitate complex surgery, and in some distressing cases can inflict more significant disability and pain than the very fall they were prescribed to prevent. Furthermore, there is another concerning condition known as osteonecrosis of the jaw, a painful and slow-healing deterioration of the jawbone, which disturbingly can be triggered by the very medication meant to strengthen your skeletal system. Concurrently, and this is the vital piece of information that absolutely should be central to every conversation concerning bone health, the single most effective intervention for meaningfully reducing the incidence of fractures in adults over the age of 65 is unequivocally not a medication. It is, instead, comprehensive fall prevention. This encompasses targeted balance training, with studies specifically on practices like Tai Chi demonstrating its ability to reduce fall risk by nearly 50%. Other crucial interventions include systematically removing potential trip hazards from the home environment, strategically installing grab bars in bathrooms, meticulously reviewing all current medications for dizziness as a potential side effect, and ensuring annual vision checks are performed. These proactive, non-pharmacological interventions genuinely reduce your actual fracture risk far more effectively and meaningfully than the majority of pharmaceutical pills, and critically, they come with absolutely zero systemic side effects. Consider the case of Gloria, a spirited 72-year-old former elementary school teacher from Phoenix, Arizona. Following her annual physical, she underwent a routine DEXA scan and was subsequently informed that her bone density was below what was considered normal for her age. Her doctor, without hesitation, prescribed a bisphosphonate on the very same day, instructing her to take it indefinitely. Gloria came to me 3 years later, complaining of a persistent, aching pain in her thigh. Upon investigation, it was discovered to be an early atypical stress fracture. Shockingly, Gloria had never experienced a fall, nor did she have any prior history of fractures. She was taking medication specifically to prevent a fracture, and tragically, that very medication was the culprit, causing her bone to react adversely. Before you automatically accept medication, what question should you ask? What is my true individualized fracture risk based on my complete health profile rather than solely on the scan result? And critically, can we thoroughly compare the potential benefits I might derive from medication versus those from a rigorously structured fall prevention program? This question is neither difficult nor confrontational. Any truly conscientious and patient-centered physician should wholeheartedly welcome it as an integral part of shared decision-making. Next, checkup number 3, routine cardiac stress testing without symptoms. This particular item frequently takes people by surprise, as it appears, on the surface, to be an exceptionally responsible and prudent medical recommendation. Your doctor might suggest, "You're 68 years old, let's just ensure your heart is functioning optimally." This typically involves either walking on a treadmill or receiving a medication that temporarily induces stress on your heart, while medical professionals diligently monitor your cardiac response. What, one might reasonably ask, could possibly be wrong with such a seemingly sensible approach? Herein lies the critical problem, one that is almost never openly discussed within the confines of the examination room. Cardiac stress tests performed on individuals who are entirely asymptomatic, meaning they experience no chest pain, no unexplained shortness of breath, and no dizziness triggered by physical exertion, possess disturbingly high false positive rates, which can, in certain populations, reach as high as 40%. This implies that in nearly half of the cases where an abnormality is flagged, your heart is, in reality, perfectly healthy. However, the medical system is generally unable to simply disregard an abnormal result. This false alarm then propels you into the subsequent, more invasive phase, a cardiac catheterization. This procedure involves threading a thin, flexible tube through your blood vessels, typically accessed via your wrist or groin, directly into the chambers of your heart. The risks associated with a catheterization are substantial, including bleeding, damage to blood vessels, cardiac arrhythmias, and in rare but alarming instances, the catheterization itself can inadvertently trigger the very heart event that the initial screening was intended to prevent. Furthermore, if the catheterization reveals a partial blockage, a condition that is extremely common in adults over 65, including many who will live decades more without experiencing a single cardiac event, you might then be advised to receive a stent. Now, this next point is absolutely crucial, and one I implore you to truly absorb. Multiple major clinical trials, including the landmark ischemia trial, which stands as one of the largest studies of its kind, have conclusively demonstrated that stenting in patients with stable coronary artery disease did not significantly reduce the incidence of heart attacks or extend life expectancy when compared to a comprehensive regimen of medication and lifestyle management alone. To put it plainly, the insertion of a stent did not outperform the benefits derived from a consistent 30-minute walk coupled with the appropriate medications. Yet, the stent carried all the inherent procedural risks and often necessitated years of mandatory blood thinner medication, introducing its own set of potential complications. Therefore, the cascade effect in this context unfolds as follows. An individual feels perfectly fine, undergoes a routine stress test, receives a false positive result, proceeds to a cardiac catheterization, has a stent implanted, is then placed on blood thinners, and enters a cycle of ongoing medical monitoring, all without any statistical improvement in their actual cardiac outcome. This is the complete and often unseen picture, and it began with the simple, well-intentioned phrase, "Let's just check." If you are finding this information valuable and insightful, please type the number 3 in the comment section below. It is a straightforward way to let me know you are following along and genuinely helps this channel reach a wider audience who desperately need this vital information. What then should you do instead if you experience no chest pain, no unexplained shortness of breath, and no dizziness during physical activity? The discussion with your doctor should not center on stress testing. Instead, it should be entirely focused on optimizing your actual modifiable risk factors for cardiac disease. This includes meticulously managing your blood pressure, cholesterol levels, and blood sugar, ensuring consistent physical activity, and prioritizing adequate sleep. These are the areas where the real and substantial cardiac health gains reside after the age of 65, and none of them require an invasive catheterization to access or improve. Checkup number 2, routine carotid artery ultrasound in asymptomatic patients. This is another area that receives remarkably little discussion, and based on the compelling evidence from medical data, this silence represents one of the most significant and potentially consequential oversights in current routine senior care. A carotid artery ultrasound is an imaging procedure designed to visualize the large blood vessels located in your neck, known as the carotid arteries, which are responsible for transporting vital blood flow to your brain. The underlying rationale for this screening might seem entirely logical. Identify a potential blockage before it has the chance to cause a stroke, then surgically clear it out, thereby solving the problem. However, the reality of this approach is far more intricate, and for individuals who are completely asymptomatic, it can be considerably more dangerous than it initially appears. Here is the undeniable fact that completely alters the entire dynamic. The surgical procedure commonly employed to treat a carotid blockage, known as a carotid endarterectomy, carries an inherent 2 to 3% risk of causing a stroke during or immediately following the surgery itself. In older adults, especially those with pre-existing health conditions, this percentage unfortunately climbs even higher. The United States Preventive Services Task Force, USPSTF, which serves as the gold standard body for establishing screening guidelines in this country, explicitly recommends against routine carotid artery ultrasound screening for adults who are entirely asymptomatic. Their analytical conclusion is unambiguous and direct. For asymptomatic individuals, the inherent risks associated with the surgical intervention demonstrably outweigh any likely benefits. Let's delve into the crucial why. A substantial proportion of adults over the age of 65 will naturally develop some degree of narrowing within their carotid arteries. This narrowing, often the result of years of atherosclerotic plaque buildup, has frequently been present for many years, remaining stable, silent, and critically not causing any discernible problems. When you routinely screen for this condition, you will inevitably discover it, and subsequently, a well-meaning surgeon adhering to established protocols will often recommend fixing it. Yet, the very surgery intended to clear a blockage that was never causing symptoms carries the perilous risk of dislodging a small piece of plaque. This dislodged fragment can then travel directly to the brain, precisely initiating the very outcome, a stroke, that the intervention was originally meant to prevent. The irony is stark and tragic. The intervention itself becomes the cause of the problem it sought to avert. What, then, should be done instead? If you are experiencing no neurological symptoms whatsoever, no sudden, unexplained vision changes, no facial drooping, no weakness in your arm or leg, no brief episodes of confusion or slurred speech, routine carotid screening is generally not recommended. And critically, this is not where your healthcare energy should be directed. Your efforts should be channeled towards proactively managing the actual modifiable drivers of stroke risk. The single biggest one is blood pressure. Meticulous control of hypertension is paramount. Other crucial factors include blood sugar management, addressing atrial fibrillation if it applies to you, and consistently maintaining an active lifestyle. However, if you do experience any of these symptoms, even if they are brief or seem to resolve quickly, that absolutely changes everything. In such cases, you must seek immediate medical evaluation. At that point, it is no longer about routine screening. It is your body sending a clear, urgent signal that demands an immediate and decisive response. Finally, checkup number 1, routine colonoscopy after age 75 in low-risk asymptomatic adults. This is arguably the most challenging recommendation to question, largely because colonoscopies have been so thoroughly and universally endorsed for such an extended period that challenging their utility, even in the appropriate context, can feel almost counterintuitive and even irresponsible. However, the comprehensive data specifically for adults over the age of 75 particularly those who are entirely asymptomatic, have a history of clean prior colonoscopies, and possess no family history of colorectal cancer, tells a significantly different story than what most people typically hear. The United States Preventive Services Task Force, USPSTF, explicitly recommends against routine colonoscopy screening for average-risk adults who are over 75. Their rationale is not ambiguous or open to broad interpretation. It is rooted in the clear understanding that, for this specific demographic, the inherent risks begin to decisively outweigh the potential rewards. And these risks are profoundly real, becoming startlingly concrete once you grasp the full spectrum of what can potentially go wrong. Bowel perforation, a literal tear in the wall of the colon, occurs in approximately 1 in every 500 colonoscopies. For a younger adult, while serious, this is typically a manageable surgical complication. However, for a 77-year-old, a bowel perforation can tragically escalate into an emergency surgery, potentially necessitating a colostomy, a surgically created opening for waste, leading to an extended and debilitating hospitalization, and culminating in a recovery period that can permanently alter their independence and significantly diminish their quality of life. And this grave risk does not even account for the preparation process itself. The infamous bowel prep liquid designed to thoroughly cleanse your colon before the procedure can, in older adults, induce dangerous levels of dehydration, severe electrolyte imbalances, and significant cardiac stress. Furthermore, there is the inherent risk associated with sedation, which escalates considerably with advancing age. Returning to our longevity lens, it is crucial to understand that the types of colon cancers most likely to be discovered in asymptomatic adults over 75 tend to be slow-growing. They progress at such an indolent pace that in many cases they would never cause any problems or impact that individual's health within their remaining natural lifetime. Allow me to share the poignant experience of Margaret. Margaret, a resilient 78-year-old retired school teacher from rural Ohio, had undergone 2 colonoscopies in her 50s and 60s, both of which were completely clear. No polyps, no family history of colorectal cancer, and no symptoms of any kind. When she saw a new primary care doctor, he reviewed her chart and promptly informed her that she was due for another one. Margaret, being a thoughtful and proactive patient, asked several questions, but was repeatedly reassured that it was merely routine. Trusting the medical advice, she proceeded with the plan. The bowel preparation, however, profoundly impacted her system. By the following morning, before she could even reach the procedure, she was disoriented, acutely weak, and barely able to stand. Her concerned daughter immediately took her to the emergency room. Her electrolyte levels were critically low, and her heart was under severe strain due to the dehydration. Margaret spent 5 harrowing days in the hospital, never actually undergoing the colonoscopy. The stark findings from those 5 days were devastating. Her heart and kidneys had been severely stressed by a procedure that was intended to screen for something she almost certainly did not have, and even if she did, she would, with high probability, have outlived it. When Margaret called me after her discharge, her voice filled with profound weariness, she lamented, "I felt better when I was overdue for that test than I did after trying to take it. What then should be done instead? Engage in a conversation with your doctor about non-invasive stool-based testing options, such as the Cologuard test or an annual fecal immunochemical test, FIT. These methods can effectively flag genuine warning signs without any of the procedural risks associated with a colonoscopy. However, it is absolutely vital to emphasize that if you do experience symptoms, such as blood in your stool, unexplained changes in bowel habits, like persistent diarrhea or constipation, or chronic abdominal pain, that fundamentally changes the equation entirely. These symptoms demand immediate and thorough evaluation, irrespective of your age. Now we arrive at the practical piece I promised you. Every single time a physician recommends a screening test, particularly if you are over the age of 65 and feeling perfectly well, I want you to have 5 crucial questions readily available. Write them down, store them in your phone, bring them to every single appointment. These questions are your tools for empowerment and informed decision-making. Question 1. What is the false positive rate of this specific test in people my age? This question is incredibly important because it reveals the likelihood that the test will erroneously flag an abnormality, thereby sending you down a potentially unnecessary and risky path of follow-up procedures, even when absolutely nothing is genuinely wrong with you. Question 2. If this test does find something, what are the realistic and practical treatment options available for someone of my specific age and overall health status? Do not allow the conversation to terminate simply with the statement, "We found something." You must actively push the discussion further to the critical point of, "And then what happens? What are the concrete next steps, and how do they apply to me?" Question 3. What is the procedural risk profile of the treatment we would most likely pursue? Every single medical procedure, no matter how minor it may seem, carries an inherent set of risks. You have an absolute right to be fully aware of these potential risks before you consent to the procedure, not discover them after the fact when it's too late. Question 4. What are the potential outcomes if we choose to monitor this condition instead of treating it immediately? For a substantial number of conditions discovered in older adults, a strategy of watchful waiting, carefully observing the condition's progression without immediate intervention, is not only a legitimate option, but often a superior one. This approach is not a surrender, it is rather a demonstration of correctly performing the risk-to-benefit assessment. Question 5. What is the most effective, non-invasive approach for managing this condition? As you have witnessed today with discussions concerning bone health, heart health, and stroke prevention, a combination of targeted lifestyle modifications and appropriate medications frequently outperforms invasive procedural interventions, and critically, with only a fraction of the associated risks. Any physician who is genuinely dedicated to your best interests and truly in your corner will wholeheartedly welcome these thoughtful and probing questions. They will not make you feel difficult or troublesome for asking them. In fact, such questions facilitate a deeper, more collaborative dialogue. Conversely, if a doctor dismisses these questions out of hand or makes you feel as though you are being a problem patient for raising them, that itself is extremely valuable information. It serves as a crucial indicator regarding whether that particular doctor is truly the right fit for your long-term healthcare needs and philosophy. Here is what I strongly encourage you to try, starting today. Before your very next medical appointment, whether it is scheduled for next week or 3 months from now, take a moment to write these 5 essential questions on a small note card or input them into the notes application on your smartphone. Do it right now, this very hour. Bring that card with you to the appointment. You may not feel the need to utilize all 5 questions. Perhaps only 1 or 2 will be pertinent. However, the mere act of having them with you profoundly alters how you present yourself and your mindset within that examination room. And how you approach that room, how empowered and informed you are, directly impacts what ultimately happens to your health and well-being. Commit to doing this for the next 30 days, for just 1 appointment, these 5 questions, and I can confidently predict what you will observe. By the end of those 30 days, you will perceive yourself as an entirely different kind of patient. Not a difficult one, but rather a protected one, someone who possesses a clear understanding of the true purpose of diagnostic tests, what the subsequent follow-ups genuinely entail, and, most importantly, precisely what questions to ask before the diagnostic treatment cascade ever has a chance to begin. There is undoubtedly someone significant in your life, a spouse, a sibling, an adult child who responsibly manages their elderly parents' health, who desperately needs to hear the crucial information we have discussed today, ideally before their next annual physical. You do not need to undertake the burden of explaining it all to them. You can simply send them this video, allowing the message to resonate directly. If this profound conversation has fundamentally changed your perspective on routine medical care after the age of 65, I strongly encourage you to subscribe to this channel. Next week, I will be delving into a topic that connects directly and powerfully to everything we have explored today: the specific medications that are routinely prescribed to adults over 65, which at that age carry a completely different and often significantly higher risk profile compared to when they are taken at 50. I will also equip you with essential questions to ask your pharmacist before you ever refill these prescriptions. If you currently take more than 2 daily medications, that upcoming video was specifically created with you in mind. Please leave a comment below and share your experiences. Have you ever had a routine test lead you down a path you did not anticipate? Your personal experience in that comment section might be precisely what someone else needs to read before they walk into their next medical appointment, providing invaluable insight and reassurance. Take good care of yourselves, and I look forward to seeing you next week.